Good evening, members. I hope I can be heard. We've given the 5 minutes and I can see the quorum is up to 70, so we're doing well. The rest will join in as we go along. My name is Dr. Winnie Mwangi, Anaesthesiologist at Nakuru Level 5 Hospital. I'll be your moderator for this evening. Joining us, our speaker for today, we have Dr. Mwemezi Kaino. He is currently the chair of anesthesia and intensive care at Kio Hospital here in Kenya. He's also been the chair of intensive care and anesthesia in Tanzania at Kilimanjaro Christian University and also the college. We'll be discussing challenges in ramping up critical care medicine in low to middle income countries and the lessons we've gotten from COVID. Dr. Kaino, you have the floor.
Okay, thank you. Can you hear me?
Yes, we can, yes.
Oh, thank you very much. Good evening, everyone. Critical care medicine is considered to be somehow neglected in the low middle income countries. And historically, the major healthcare transformations have occurred due to crisis in healthcare systems, such as the COVID-19 pandemic. For example, the blood banks that were built around HIV prevention. That is swapping challenges for solutions. My name is Dr. Mwemezi Kaino, as I'm introduced. I'm an anesthesiologist from Tanzania, living in Kijabe, Kenya. In Kijabe, we have two hospitals, namely Kijabe Hospital and highly specialized orthopedic hospital called AIC Cure International Hospital, where we treat children with skeletal malformations, and for adults, we do surgeries of spine, total knee replacement, total hip replacement, sports medicine, and pain management. Today, I will talk about challenges in ramping up critical care medicine in low middle income countries, learning from COVID-19. I have chosen this topic because it has many unresolved challenges that prohibit forward and backward referrals in healthcare systems, leading to preventable deaths of our citizens. It is going to be an interesting talk, so I just suggest you back her up.
Before Dr. Kaino continues, please keep your microphones muted along with your videos as well, so we can pay attention. Thank you.
Before we start, I would like all of us to ask ourselves these concerning questions. Why is critical care so poor in Africa? And what can be done to improve it? And whose job is it, really, to improve it? And what's the role of the private sector? And this is my outline. In the overview of critical care, I will touch base with some definitional attributes and non-standards, standard features of critical care medicine. Under the unique features of critical care medicine, I will describe the current status of critical care medicine in this region and elucidate the challenges that need transformation. Under the opportunities in scaling up critical care medicine, I'll try to explain the possible ways to swap challenges for solutions. So additional to the standard features of critical care medicine that we're going to discuss in this section, I will also set a style based upon which the rest of our talk will take shape. During preparation for this slide, for this presentation, I called several colleagues to ask them about certain features of ICU, the standard features of ICU, and discovered that most of them did not know very well about them. So this section will be the longest of them all, but I'll try to go a little faster because it will explain very familiar details. So by definition, critical care is an advanced and highly specialized care provided to patients whose conditions are life-threatening and require comprehensive care and constant monitoring. It encompasses diagnosis and treatment of a wide variety of clinical challenges that represent the extreme of human disease. Critical care medicine can be provided in an ambulance, in emergency medical department, in cath labs, in operating theaters, general wards, HDU, and in ICU. This is to say that it is a service and not a place. Although from all these departments, those patients with potentially reversible conditions will eventually be admitted in ICU for a prolonged treatment. And therefore, in this presentation, we will use the term ICU as a representative location to describe features of critical care medicine. And these two terminologies will be used quite interchangeably throughout this presentation. So these are different models upon which to classify critical care medicine. Level 3 is for multi-organ failure. Level 2 is for impaired vitals and single organ dysfunction requiring monitoring, pharmacological, and device-related support. Level 1 for care after major surgeries or patient in compensatory phase of their illness. Level 0 is generally a general ward. And a high dependence unit is somewhere between level 0 and level 1. Sometimes it can be a separate unit from ICU, sometimes it is mixed. But when mixed, it can be tricky to deny ICU service to HDU patients. On the slide, PNFP is a private not-for-profit, the last word there. But ICUs can further be divided into neuro, cardiothoracic, obstetric, etc. Generally, critical care medicine is a large, sophisticated healthcare sector with a lot of moving parts, and describing its features and transformation needed me to adapt a poor farmer's approach of 4 S's, as shown in the next slide. This is the poor farmer's model for transforming healthcare system. And the 4 S's stands for space, that is place, staff, for human resource or workforce, staff for the hardware, as I would like to call it, the technology and consumables. And finally, system for the software, as I would like to call it again. Clinical guidelines, strategic plans, curriculum for training, policy and regulations, all of those go into the system. This model will be used to guide our presentation from this very point that we are talking about the features of critical care to the end of our talk. Now, this section of critical care features will discuss the space of an ICU, as you can see it on the photo. In a country, ICUs should be adequate in number and equitably distributed, not all in one city, the capital city. In a hospital, an ICU should be located at a suitable location for convenient connections to the emergency department, operating rooms, cath labs, etc. Generally, the size and type of therapies are influenced by the volume effect correlation. Building hygiene should involve proper management of clean and dirty water, control temperature, humidity, light, and ventilation, which can be balanced between natural and artificial. Microclimates affect well-being of care providers and patient outcomes. Material used for walls, floor, and roof should be impervious and sound absorptive. Considerations for smoke and toxic gases, which involves containment, that is use of resistant material, or disposal, or pressurization for prevention of smoke entry must be implemented when building the ICU. So we're still talking about space. Floor layout should include all the sections listed on this slide with their corresponding floor recommendations, floor area recommendations. So you can see that's a lot of space for just an ICU. Nursing stations should be situated in a way that nurses can see patients and monitors. Number of isolation rooms with negative pressure should be at least 1 to 6 isolation rooms per 10 ICU beds, depending on where the ICU is. And they should be preceded by an anteroom of about 3 meters square. Storage area of about 10 meters square area per ICU bed should be located within 30 meters from the patient space. These are the recommendations of an ICU. Still talking about space, we have number of ICU beds is conventionally agreed to be about 5 to 10% of the hospital's total bed capacity. National health insurance funds in some countries have guidelines for what they would consider to be an ICU. In addition to these features, the guidelines will stipulate the minimum number of beds in an ICU, usually a minimum of 6 and an optimum of 8 to 12 beds. But in other countries, universal coverage is preferred and the service available is provided to as many people as possible. Minimum interbed space is of about 1.75 meters, or a floor area for a bed space of about 20 square meters in a common room, or 25 square meters in a single room. The whole ICU should be at least 3 times the total area devoted for patient care. A critical care bed, as some will call it an ICU bed, is not just a bed, but a collection of items such as electrical functional bed, mattress, ventilator, suctioning machine, etc. There should also be provision for compressed gases and a minimum of about 6 socket plugs located at a height of between 120 and 180 centimeters from the floor. And now we're going to talk about equipment, consumables, and spare parts as stuff. Source of compressed medical oxygen and air is important for blending various FiO2s and for running pneumatic ventilators. This could be wall supply or cylinders. Remember, a backup cylinder or a concentrator is paramount. Most ventilators operate at a supply pressure of around 50 psi and a flow of about 80 liters per minute. Excessive pressures will damage the safe valves, and there will be excessive leak and malfunctioning of the ventilators. A power conditioner should be used to deliver electricity to all devices and machines. Remember to have a backup generator. Telecommunication will involve telephone, intercom, manually triggered alarms, large wall clock and calendars, computer, and internet. Essential to have reliable supply chain and PPM arrangement, as PPM stands for Planned Preventive Maintenance. Still on stuff, for the sake of time, I will not list all the items because it's just too many, and most of you know them already. It's a lot of things, it's expensive, but it needs to be done. And it can be done because there is nothing more expensive than life. And always remember, buy expensive and you cry once. Now we shift into staff as in workforce. In ICU, this is divided into medical staff, nursing staff, and allied health personnel. We are starting with the medical staff. Medical director covers administrative and medical management. This position is held by a senior ICU specialist with prior degree in anesthesiology, internal medicine, or surgery for formal education. So he must have that first degree, which is master's in medicine, and must have a formal education, training, and experience in ICU, and described as it is described in the guidelines of that country. The medical director of ICU must work full-time, or 75% of professional duties must be in ICU. Therefore, he cannot hold any other higher responsibility in the hospital. ICU specialist doctors are trained for about 6 months to 2 years. Number of specialist doctors per ICU is calculated using a formula that considers the following factors, like number of beds in a unit, number of shifts per day, desired occupancy rate, extra manpower for holidays and illness, number of working days in a week, level of care, or as a function of clinical research and teaching workload. Regular doctors in ICU could be from departments such as anesthesia, internal medicine, and surgery, with a minimum training of about 3 to 6 months. So they don't get a qualification out of this. These are supervised by ICU specialists. You can have trainees in ICU. These are either specialists or residents in anesthesia, surgery, internal medicine, who undergo 3 to 6 months for short training without recognized qualification, or for 6 months to 2 years with recognized qualification. They work under the supervision of specialist intensivists. Nurses are important because they spend a lot of time with patients than doctors. A certified critical care nurse must have completed a formal training in critical care and emergency medicine. They perform all the nursing activities in ICU and report to ICU specialists or regular doctors. Now you can see on this slide the nurse-to-patient ratio that is recommended. LOC stands for level of care, and at level 3, you need a ratio of 1 to 1, level 2, 1 to 2, etc. Other staff include occupational therapists, clinical pharmacists, administrative, and cleaning personnel. Still talking about staff, when talking about human resources, it is important to talk about professional bodies, which can be national, regional, or global. For example, the World Federation of Intensive and Critical Care. This is largely for physicians, and the World Federation of Critical Care Nurses. They have a role to play in our profession. And now I'll talk about standard systems. So shifting to systems which are like the software for smooth operating in critical care medicine, these include clinical pathways such as admission and discharge criteria, which can also be protocolized or non-protocolized, as well as effective supply chain and reliable planned preventive maintenance arrangements. And now we will go through the special features of critical care medicine in sub-Saharan Africa. This is our second point on the outline. I will use the format of 4S as we've used it before, and we will review a few studies done in our region, starting with space. A study that was looking at ICU capacity in Uganda found out that there were only 12 ICUs in the whole country, most of which were located in the capital city. Generally, by proportion, private hospitals had more ICUs than public hospitals. And not so seldomly, ICU location in hospitals was in places not meant for ICU. Therefore, most of the accompanying structures like we've seen above, like offices and storage, were not described because they were not there. On the same study, it was found out that the floor space area per bed was on average of 6.2 meters square, which is less than the recommended, which is 20 to 25 meters square. And only a quarter of the surveyed ICUs, a quarter, had isolation rooms. The study did not explain the features of the isolation rooms found in other ICUs. I was not lucky enough to find studies conducted in our region that described ICU structures and included, sections such as storage, office, nature of surfaces, as well as overall location of an ICU in relation to other departments in the hospital. So we'll go to staff. Staff as equipment. This data is summarized from updated data that was published by the Center for Disease Dynamics, Economics, and Policy. And it shows how few the ventilators and beds are in some sub-Saharan countries, compared that to other countries. It is interesting to see a larger number of ventilators per ICU bed in some countries, like Uganda, 100 ventilators for 55 ICU beds. Maybe this explains about the quality of data, or perhaps about the overcorrection, or maybe the two data were collected at different times. ICU technology is expensive. Consequently, most of the little available in sub-Saharan Africa is obtained through donations. The problem with donation stuff is having different makes of the same equipment. And so it is difficult to have planned preventive maintenance arranged with specialized personnel. Also, it is difficult to get spare parts. So increasing the number of biomeds in sub-Saharan Africa may not solve this crisis of preventive maintenance and equipment graveyard. This map of Africa by Reuters showing number of ICU beds by country. I've summarized a bit of this in the next slide. As you can see here, the first observe that there is no data for about 17 countries. Data paucity, which in itself is a roadblock to making any progress. 3 countries had no ventilators, 0. 7 countries have less than 10 ventilators. And half of the countries in the continent have less than 100 ventilators. Reuters again showing the continent's 3 giants by population, Nigeria, Ethiopia, and Egypt, having only 1,920 ICU beds for more than 400 million people. That is equal to 0.5 ICU beds per 100,000 population. I've not come across a reference number of ICU beds per population, but UK exceeds this average by a factor of 20 and reports that are still in short supply. Finally, just emphasizing on data paucity, in sub-Saharan Africa, there is a comment on this slide that the Minister of Health in Central African Republic, pardon me, the Minister of Health in Central African Republic learned from an aid agency that the country had only 3 ventilators. And the minister said he had no idea they had any. Well, can you still hear me? I see that my internet connection is unstable.
Yes, Doc, we can hear you.
Oh, thank you. So at least that is a very serious data paucity, you know. That's a very serious data paucity. That need to be addressed in our region. The thing is, if you don't measure the presence, magnitude, and impact of a challenge, then it does not exist. So we need the numbers. Some study conducted in Uganda found that 100% of the ICU had backup generators, which is good in itself. But maybe it would have given us more insight if it had also mentioned the frequency at which the generators are used. Infrastructure like roads, power supply, dirt and clean water systems, oxygen industry need to be prioritized in the nation. If infrastructure, if we have to do any transformation in critical care medicine and healthcare in general, if we are intentional about it. There are many good initiatives in critical care medicine and healthcare in general, but it is the system at large that need to be structured first. Now let's take a look at staff, which is the human resource and workforce in critical care medicine in sub-Saharan Africa. So most of the physician staff working in ICU are anesthesiologists, as we have very few intensivists who have completed formal fellowships. In this study, 75% of the ICU directors were anesthesiologists, and generally, ICU doctors composed mostly of anesthesiologists. I wish I had a way to point on my slides here. Anyway, I hope you can see those numbers on the slides. There is shortage of nurses too, as shown by this high nurse-patient ratio of more than 1 to 4. Also, most of the nurses working in our ICUs are general nurses who have not received any additional qualification in critical care medicine. Apart from that, allied healthcare personnel are as well in high demand. From Reuters again, and this map represents number of physician anesthesiologists by country. All countries colored in black have less than 1 anesthesiologist per 100,000 population. We need an optimum of about 10 per 100,000 population, just to cover the operating rooms alone. Take a look at this histogram showing data summarized from Center for Disease Dynamics, Economics and Policy. The darker color represents non-physician anesthesia providers, and the lighter histograms represent the physician anesthesia providers. It can be observed that there are very few anesthesiologists, and by far not even enough to sustain safe, easily accessible surgery. I've tried to put this into some different perspectives on the next slide, using Tanzania as an example here. Data from NSOAP, NSOAP stands for National Surgical Obstetric and Anesthesia Plan, which is currently ongoing in Tanzania. Data from NSOAP shows that recommended number of surgical obstetric and anesthesia physicians, which is SOA on this slide, is about 20 to 40 per 100,000. So all of them, three of them, obstetrician, general surgeon, and anesthesiologist. But the current number of SOA in Tanzania is 0.5. The recommended is 20 to 40, but the number in Tanzania of SOA is 0.5 per 100,000 population. I did some simple arithmetic on this slide and the estimated time that it will take to reach optimum number of anesthesiologists in Tanzania. And I estimated it to be about 500 years. Well, I know I have ignored the fact that the number of residents will increase with time. But generally, this is a very long time. The point here is that these are the specialists we expect to drive critical care sector. And it is a common challenge across the board in sub-Saharan Africa. Transformation is needed to close these gaps. Still talking about human resource, professional bodies have a big role to play, as we've seen before. This slide discusses prevalence of professional bodies and critical care medicine in sub-Saharan Africa. In sub-Saharan Africa, the national societies of anesthesiologists are trying to form connections with critical care, but this has not been transformational in many countries. There's a good sign though, because the critical care nurses, according to the World Federation of Critical Care Nurses, World Federation of the Societies of Critical Care Nurses, the number of national societies of critical care nurses who have registered with the World Federation of Societies of Critical Care Nurses have increased from only 2 in 2012 to about 7 in 2016. Could be more by now, it's 2020. So in conclusion, we have a very small workforce, and those who are supposed to train in critical care are also very few to begin with. The national, regional, and international community have prioritized this field, have not prioritized this field yet. There is no policy, and where there is, it is weak or no implementation due to inadequate donor community involvement, ineffective lobbying and advocacy by the professional societies and a few physicians who are interested in critical care medicine. There is no critical care medicine desk at the Ministry of Health in many countries. At hospital levels, it is common that many public ICUs lack protocols, guidelines, algorithms, and checklists. Sometimes these tools exist on papers, but not practiced due to lack of leadership and or supplies. Rounding is not structured, and it is not multidisciplinary. Very few hospitals do that. A study done in Tanzania, which was looking on ICU admission practices, revealed lack of admission and discharge criteria, something that is common across the board. Data paucity makes it difficult to make informed decisions, such as making a budget for critical care medicine at various levels. The future research in this area should try to target and thoroughly study only one of the space, staff, or system, instead of partially including all in one study. At least that's my suggestion. And looking at training in Africa, we have very few intensivists who received formal registered training. Compounding that with low numbers of anesthesiologists leads to a prohibitively low teaching capacity. A few countries have started developing curriculums for critical care nursing training, but we need to do more. So generally, it's a vicious cycle. And all these factors lead to high mortality rates, increased morbidity, less work morale, less incentive in critical care medicine, and unsupported sectors of healthcare. As you can see, the ICU mortality rate in 2 studies that were done in Kenya ranges from 27% to 51%, which is very high. Now let's take a look at opportunities in scaling up critical care medicine in the context of COVID-19 in sub-Saharan Africa. I don't know how I'm doing time-wise. Some major transformations. Okay, some major transformations in healthcare industry occurred during crisis. So likewise, during COVID-19, there have been opportunities to improve critical care medicine in the sub-Saharan Africa, which were utilized by governments to a varying extent from one government to another. We have witnessed governments and donors, donor communities sensitized during this pandemic. There have been increased manufacturing, procurement, and donation of ventilators, oxygen delivering devices, and monitors. Some African countries have procured some ventilators and monitors, which came together with training opportunities in critical care medicine and IPCs, infection prevention control. The world has seen the largest knowledge sharing platforms emerge. There are many more courses online for critical care now than ever before. There have been some investments in oxygen manufacturing and delivery as well. All of this is exciting because despite the infectious diseases, non-communicable diseases burden is ever increasing, for which critical care medicine is equally paramount. But still, we have to remember that an intervention is only as good as the system in which it is deployed. So we need to tackle systemic issues here. But how can we do that? How can we do that? So this slide shows an example of how transformation can happen. So when I say transformation is opposed to improvement. Both of them are changes, but one is so much larger than the other. Okay. So this slide, it is a draft showing how NSWAP started as an idea with a lot of players and so many layers. Likewise, for transformation to occur in critical care, we need to have a global policy set that need to be adopted by Ministry of Health in our countries, and then funders will come into play. Small selective interventions can keep on happening, and they are good, but will not have a very productive outcome if the system at large is not supportive of that. Again, I wish I knew how to point a few things on the slide so that to show where things are going and where they're coming from. But the process starts from the left side of your screen, going going to the right, starting with the 2015 at the left top corner, where the World Health Assembly resolution and the first NSOAP that started in Zambia. And now you have NSOAP happening in Rwanda, Ethiopia, Tanzania, Senegal, Nigeria, Madagascar, etc. And you have other countries also getting ready to do that. So you need global advocacy involving WHO, Lancet Commission, WFSA, etc. And then you go to the national advocacy, where you involve COSEXA, CANEXA, and Ministry of Health and Societies. And then you go to resource mobilization for national surgical initiatives, and in this case would be for national critical care initiatives. So an example is on this slide here, where we see quite a number of ventilators being donated, and it shows number of ventilators donated versus the number of critical care workforce. They're not matching. In some countries, you have so many ventilators donated and there is no MD anesthesiologist. Okay. So you wonder who is gonna, train people how to use that device, and what will be the outcome. Ventilators without proper training of providers will lead to poor outcomes. Some companies have recognized this and are investing heavily in training as well, making the technology as an excellent platform on which to deliver knowledge and skills. And they're already in our neighborhoods, in our countries. According to my experience, simulation method of training is very effective. I've been doing it for like 6 years now, and it is the most effective way of teaching anybody if you want to transfer skills. Create that muscle memory. The psychomotor association. So it can be deployed in critical care medicine and beyond. I'm wrapping up my presentation here with just a list of organizations that I have happened to work with. Cure International is a satellite center for American Heart Association, and we train basic life support, advanced cardio life support, and PALS, Pediatric Advanced Life Support, and you get certified by American Heart Association. We've worked with Smile Train, and Smile Train is helping to build an ICU here at Cure. So it is in the final stages. I've worked with TETS, which is from UK, and I got a grant from them that we used to develop a national, to start at least. It played part in developing the national curriculum for nurse anesthetists in Tanzania. I've worked with Lifebox, and they've been, offering a lot of pulse oximeters to all the trainees. When I was at Kilimanjaro, my hospital was the major training center for nurse anesthetists, and all nurse anesthetists who graduated from that center were given a pulse oximeter. And for most of them, that was going to be the only monitoring gadget in their hospitals upcountry. And last but not least is a list of training courses that there is so many of them right now online. I don't have to list them. But if there is any young anesthesiologist out there who would like to train in critical care, you can try the medical training initiative, I think, in Royal Liverpool University, and you can have a 1 to 2 year training in critical care. There are very good resources online or websites for simulation-based training. Impact is soon enrolling in Tanzania for training using simulation, and many other online courses in critical care medicine. I think there are critical care courses in India where you can get certified, et cetera, et cetera. So I think there is a lot of excitement now than ever. Apologies, I tend to forget to change, the slides on both computers, but it doesn't lag that much. So generally, the lessons learned is that during COVID, we have learned things like, that the simple critical care medicine interventions are the most effective usually. Knowledge to recognize critical illness, as it is taught by basic DHS from, which is led by Charles Gomez from Hong Kong, that you have to recognize signs of compensation so that you intervene at that particular point to prevent organ failure and ICU admission. The use of oximeter to diagnose hypoxia, oxygen therapy, and vital monitoring. Probably a few patients developed ARDS in sub-Saharan Africa and required mechanical ventilation, but majority of patients would get better just by oxygen therapy. Maybe the second most effective, proven to be effective therapy for COVID maybe is the steroid. But knowledge to, so there are many courses and curriculum out there that you can adopt in your country or in a region and use that to train workforce in critical care medicine. Okay, but probably the challenge again is the teaching capacity, because we're very few people who can teach this. But always remember that change starts with you. One person can cause a lot of changes. Thank you. Can you still hear me, Mwangi?
Yes, we can. Yes.
Oh,
Thank
very
you
good.
so much, Dr. Kaino. That was a very thought-provoking and interesting and very insightful presentation. Thank you for preparing it for us and enlightening us. If there are any questions, please do push them on the chat box and we will answer them in a bit. For now, I would like to invite Mr. Kennedy Otieno from Gradian, the Technical Service Manager. He's going to give us a quick chat as our product presenter for this evening. Welcome, Mr. Otieno.
Thank you. Winnie, can you hear me?
Yeah, I can hear you.
Clear, loud and clear.
All right, thank you. Just trying to share the slides, very few slides. I don't want to dilute what Dr. Kaino has shared with you. I just want to introduce you to Gradian Health Systems. But first of all, before I go there, I will want to thank, allow me to thank KSA for giving us this opportunity to partner with you on this noble goal. I am Kenneth Kaunda, Technical Service Manager with Gradian Health based in Nairobi. And allow me just to talk briefly about Gradian. Can you see my slides?
Yes, we can.
Oh, thank you. Gradian Health System, sorry, Gradian Health System is a non-profit medical technology company based in USA, and our headquarters is in New York. But we have also offices here in Nairobi and in Dar es Salaam. We are an innovative company that tries to ensure that we fill certain gaps that probably some medical equipments might not be able to fill. We believe that medical equipment can only be a catalyst for global health if it is designed for a setting which is used and is supported once it is there. And because of this belief, we combine world-class medical technology and supportive services, that is local clinical training and technical support to overcome barriers in delivering high quality anesthesia and critical care. When you probably most of you have heard of us, some may not have, but I want to let you know that we have been here for some good time. We are in several countries in Africa and in Asia, and we have an installed base of over 1,000 equipments, both for critical care and anesthesia. We are in over 700 facilities, and we partner with distributors to ensure that equipments that we supply are maintained and there is a technical and clinical support. And so within our region here, we have over 70 plus clinical trainers that when we sell a machine, we don't only do technical training, but we use clinicians to be able to talk with their fellow clinicians so that they can be able to understand the machine better. But within that also, we have over 200 certified biomeds that we train to ensure that we support all the equipment that we supply. I want to let you our model, which we believe has helped us to move so fast within a very short time, because we believe, still as I said, that medical equipment can be a catalyst in global health, but only if it is designed for a setting which is it is used and supported once it is there. And because of that, we try to optimize equipment used through reliable technical support and high quality product and clinical refreshers. So when you look at our model, we have a very high quality technology equipments. And as we go on, we realize that most of our equipment are all CE or FDA marked and approved. And once we have deployed our equipment, we ensure that wherever our equipment is, we support it technically, we train the users, and we have of recent developed several simulation labs to enable us train more and more users and to give the users confidence of using our equipment. And so allow me just to take a short time to brief you on some of the equipments that we have. Probably most of you have seen them. Some might not have seen them, but I want to introduce you to our flagship machine called UAM, or Universal Anesthesia Machine. Universal Anesthesia Machine is our flagship product, and it is built to overcome unreliable infrastructure and also to provide high quality care. So UAM is designed to work in areas where infrastructure is not well developed. And so it is a machine that generates its own oxygen, and it gives this confidence to an anesthetist or whoever is using it that you can be able to do a case at any time so long as there is power. But again, also it can be able to be connected to a cylinder so that when power goes off, you have a backup of a cylinder. It is a very ideal for areas where we have challenges of oxygen and where we have unreliable power supply. It has a touchscreen ventilator, which has a battery of 6 hours. Should power go off, then you are ready to work with it for 6 hours. And it comes with patient monitor. But one thing that is important that I want us to go home with is that these machines are supported for 3 or 5 years warranty, so that once you buy it, you are not worried on how it will go for the next 3 or 5 years. And so we have several technical people who will be able to follow it up and ensure that it works. And we also, as I said earlier, have several clinical trainers whom we use, who will always train and mentor as many new clinicians as much as possible. This machine has been able to be used in many countries. And as I said, we are in several countries in Africa and in Asia and South America. And it has been a machine that has really saved life. I want to come secondly to the second machine. I'm trying to move a little bit faster so that I don't dilute and you don't forget your questions. We have a machine that we call comprehensive care ventilator. As I said, we are an innovative company that tries to fill a gap probably that most machines might not be able to fill as a result of challenges of infrastructure. This comprehensive care ventilator is a ventilator that you can be able to use for post-operative care. You can be able to use it in an intensive care unit. You can be able to use it in ambulance, for emergency, depending on the configuration. All that you will need to do is to configure it to your setting, whether you want to use it for an ambulance or whether you want to use it for ICU. And it comes with 7 hours battery backup internal, and then another 14 hours battery backup. So in case you want to go for a very long transport, a very long journey, you have 21 hours of battery backup. And it also has a provision for multiple oxygen sources. It is one of the machines that is able to, one of the vents that is able to use an oxygen concentrator. Sometimes when we are in high-end hospitals, we don't think that it can reach a point where there is no oxygen. And so what is only available is a concentrator, not for a long time, but probably for a shorter time. And this machine is able to be able to use an oxygen concentrator. It is meant to be used in a very difficult environment. But not only that, all our equipments are CE and FDA approved. I want to bring you to the last product that we have, and that is Gradian CAM, classic anesthesia machine. We've realized that while UAM is able to work in certain areas, it might not fit in certain settings, or whatever we try to, that gap that UAM try to fill, sometimes that does not exist in certain environments. For instance, UAM might be very useful in a rural setup because of the gaps that it will fill, while it might not be very important, or those gaps do not exist in a town setups like Nairobi. And so we came up with another machine that is classic. We call it classic anesthesia machine. Gradian CAM is a fully integrated economically positioned ventilator and has CO2 absorber, just like any other modern or usual anesthesia machines or classic anesthesia machines that you have. One thing that makes it a little bit unique is that it has automatic agent identification. It has 6 ventilation modes. The ventilator has 6 ventilation modes. And it is supported just like we support other equipments, both with clinical training and technical support, so long as it is in your center. I've talked very fast, and I'll want to let you know that Gradian Health System has a lot of supportive services. We have technical support, we have training, and I want to stress so much on the training that one of the pillars or one of the models that we use in our delivery of our mission is to train. And so we as Gradian actually has built several simulation labs in various countries in Africa. Currently, I think we have 6 simulation labs to enable our people to be trained and to develop that confidence and be mentored. Currently, we are almost finishing a simulation lab in KMTC, which KSA will be, I know, will use very much. And this is because we believe that a machine will not work well unless it is designed for a particular setting and it is supported both clinically and technically. And so I want to thank you so much for giving us an opportunity, and want to stress that Gradian is your partner for long term. For we'll deliver to you very high quality equipment, which with all certifications, will be able to support your equipment as long as you want it to be there, and we'll be able to support you with the trainings. At any given time, we always train and retrain because we realize job mobility is very much in most of our hospitals. So when your people leave, we'll always come and retrain and retrain. And that is what makes us a unique company. In case you want more information for any of the specifications or anything, please, you can be able to contact us. And thank you so much for giving us an opportunity to work with you.
Thank you so much, Mr. Otero, for that chat. Personally, I have used your ventilators, especially for transport for critical care patients towards radiology for CT scans and such, the portable one. And I have to say I'm a very happy camper. And yeah, commended for, and we appreciate that you also did come and train us. We might need a retraining though, but yes, it's actually a very good vent to use. We're going to jump right into the questions. Thank you. So let's just start off by saying, Pax, thank you so much. You're starting training for anesthesia beginning January 2021. That would be one way actually you should be addressing the number of anesthesiologists you have in the country, because as you say, it's very minimal. The first question was coming from Miles Monaghan, who asked, how can we help in terms of education? And is there room for opportunities of training via Zoom? Dr. Kaino.
Is Mars still around? Mars, thank you so much for reaching out like this. I know him personally. We've worked together in Kilimanjaro. He's a Lifebox fellow there. So yeah, there's a room for this. And this kind of training, I think, can improve critical care, but it's a very gradual way of doing it. As I've said, critical care is so neglected that we need transformation. We need major investment and policy change that can improve this. So yes, webinar trainings, already so many of them online. are very helpful to actually update and refresh clinicians and actually teach a few people. But if we want to teach a massive amount of people and transform this sector of healthcare in this part of the world, then we need major game changers. I hope after COVID, maybe you will not be only teaching on webinars, but you will be able to actually organize certain training and come out and teach people physically. There are many courses that you can adopt in your universities and in your hospitals and teach staff and students, like the basic DHS from the collaboration of intensivists chaired by Professor Charles Gomez at University of Hong Kong. They collaborate with Medicine Sans Frontier, which is, they have very nice courses for undergraduate students, for residents. Actually, there are some universities along the, in countries along the Mediterranean and Middle East that will not allow a resident in any field, it be dermatology or ophthalmology or whatever, to proceed to start actually the residence training program without passing that course. So some take it very seriously. It is very good in getting clinicians to recognize early signs of deterioration and train them to mount an equally aggressive intervention at that point to intercept deterioration and organ failure and avoid ICU admission. Because all over the world, we know outcomes from ICU are not very good. And that's why I was emphasizing about, you know, critical care being not a place, but the service you offer, and you can offer that anywhere where the patient needs it. You don't have to take your patient to ICU for resuscitation. You have to resuscitate the patient where they are. When they are stable, look if they have a critical illness, which is possibly reversible, and take them to ICU. So, I don't know, anything little that you can do will be helpful. But if we need transformation, we need to look at a broader picture and learn from specifically NSWAP on how we can tackle critical care in our countries. Mwangi?
Thank you so much, Doc. That was actually a very thorough answer. Yes, I believe there is room for telemedicine, definitely, going forward. It would be nice if I'm in Nakuru and I have a patient and I'm not quite sure what to do, how to go about it, to be able to talk to you down the road in Kijabe or in Tanzania and actually be able to sort out the patient. Thank you for that answer. There are quite a few questions regarding the Gradian ventilators. I know they've put up the email address on the chat box. If you can see it, it's info@gradianhealth.org. So that's info@gradianhealth.org. So you can reach them there if you have any more questions, but I felt that we should take some of them. One, I think Mr. Ochen already answered. Are you still with us?
Yes, I am.
Okay, yeah, so there's the question of training opportunities, which I think you had answered when you said when you're bringing the ventilator, you actually do take the time to train the people who are going to be the users of the ventilator. There was a question regarding the CCV. Which category of patients is it indicated for?
Thank you so much. Let me also stress that we have a lot of material on our website for training for critical care. There's several slides, both video and written. The CCV is for five kgs, so it won't be, it's not ideal for neonates. I don't know whether I've answered that.
What's the minimal type of volume you can do on it?
The minimal volume is 40.
Okay, 40 mils.
I was looking at the tidal volume.
Yes.
Yes.
Okay.
40 minutes.
And then for the universal anesthesia machine, do you have
Yes.
vaporizer for Civo and isoflurane?
Yes.
Okay.
We have vaporizers for Civo and isoflurane.
All right. I think also the security features and the cost was one of the questions that were coming from the members. I think they can find those on your website.
We can always talk about that.
All right, we're approaching our time to end. We only have about 10 minutes left. Any last comments, Dr. Kaino, before we close?
Yeah, I think there's so much we can do in this area, and there is so much already out there that we can utilize. So we need champions to start this journey. It's time already. Many people are dying in our countries, lives that can be saved. And thank you everyone for listening. Thank you KSA for having me here. And thank you, Gradian, for being here as well.
Thank you.
Thank you, Doc. Any last comments, Kennedy?
Not really, just want to thank you for allowing us to partner with you. We are grateful for the partnership, and we are here to work together for the good of all of us.
All right, thank you for that. On my part, thank you for letting me moderate for you guys today. My parting shot will be a comment that Prof. Gumi, who's with us today, posted, was that we need to advocate for more interest in training for more critical care medicine staff. This is, at the end of the day, to improve the quality care for our patients. So let's meet again next week, same place, same time, for another CME webinar, courtesy of KSA. Have a good night, everyone.